Hi, everybody. My name is Nicole Tabola. I'm one of the LVAD coordinators up at Atrium Health in Maine. I'm here to talk about our LVADs. So for those of you who don't know exactly what an LVAD is, LVAD stands for left ventricular assist device. So essentially in a normally functioning heart, the ventricle will fill, the left ventricle, and during systole it will squeeze out about 50 to 70% of the blood through the aortic valve to the aorta and then out to the body. In someone with heart failure, the percentage of blood that's ejected is usually less than 25% for the patient population we see, which means these patients aren't getting a good amount of oxygenated blood to their organs. These patients tend to end up with organ failure and are in need of therapies that extend past the optimized oral medications, which is where we come in. So for an LVAD, there are four main parts to the LVAD. There is the pump, there is the driveline, there is the controller, and then there's a power source. So we'll start with the pump. Now, the pump is implanted directly into the left ventricle. And what it does is it pulls the blood from the ventricle, bypasses it through a graft to the aorta, and that way it can be ejected out into the body, bypassing the aortic valve completely and allowing the patient's native ventricle to be able to rest. Now, there are three different types of pumps. Two are by a company called Abbott, and those are the HeartMates, and then there's one by Medtronic, and that is the Heartware. So the HeartMates, there are two different types. The HeartMate 2 pump, and this is not to scale in terms of this, but the pump itself is. So this is the HeartMate 2 pump. It's an axial pump that spins blood through. It is connected by an inflow graft to the ventricle. This sits in a space right below the ventricle, and it's attached to an outflow graft that's to the aorta. The HeartMate 3 is a little different. It is implanted directly into the ventricle, so it does not have an inflow graft, and it spins the blood by magnets, so it completely levitates the blood. There's less shearing, less abrasiveness of the blood going through the pump, and it also is attached to an outflow graft. And then you have the Heartware, which is very similar to the HeartMate 3, as you can see. It also sits directly inside the left ventricle and is attached to an outflow graft. Now the HeartMate 2, well, all three are continuous flow devices, which means that they continuously pull blood from the ventricle and out to the aorta. Unlike a patient's native heart, where it beats, these are going to continuously run on a cycle. The only difference is the HeartMate 3, in which they implanted a mimicked pulse. So every 2 seconds, it drops its speed to mimic a native pulse. In the trials, they felt that that cut down on the risks and the rates of strokes, which so far they have proven right with that. So the next part of the LVAD is the driveline, and that is connected from the pump. Part of it is implanted inside the body, and it exits through an exit site in the abdomen, and then it will connect to the controller. Now, the place where it exits out of the abdomen is a sterile site. We teach the patient's families how to properly change this dressing. Now, something you guys will be encouraged to do is just make sure that the patient's families are practicing good sterile technique. We wouldn't expect you guys to know how to change the dressing. It's something we train them how to do, and they have to be checked off. But just to make sure that they are practicing that sterile technique, because infections, the rate of infections in LVAD patients is about 50%. And so that's another thing we would ask you to do is to, when you're assessing your patient, to look for signs of infection at that exit site, things like redness, any type of drainage. If the patient complains of pain, if you notice any bulging or swelling, any kind of odor in and around that area. If the patient complains of abdominal pain, especially in that site, has fevers, chills, anything like that, those are things that you would want to report to us because those could be signs of infection. Now, inside the driveline are wires that tell the pump tells the controller how to do its job through these wires. They can fracture if the driveline gets bent, manipulated, torn in any way. So something else we would want you to do is to make sure that the driveline is as straight as it can, free of tears, bends, things like that. Patients tend to bundle it up and put it in their pocket. And if the driveline wire gets fractured, the only way to fix that is to replace the part of the driveline that's fractured, or in severe cases, the whole pump. So the driveline connects into a controller. Now the controller is essentially the brains. We tell it what to do, it tells the pump what to do. So what we do is we set a speed, and that tells the pump how fast to eject blood from the body, or from the ventricle. And it calculates a flow, so approximately how many liters of blood is coming out of the pump, and therefore out of the heart per minute. And there's also a power, which shows how hard the pump is working at the speed we set it at. And in the cases of the HeartMate, there is a number called a PI. It stands for pulsatility index. It's essentially a measure of how well the ventricle is working versus the VAD. So if their patient has more pulsatility, their heart is pushing a little bit over the VAD, that number will go up. We like the VAD to do most of the work. It allows the ventricle to rest. It allows the patient to feel better. But in most cases, we ask you not to worry about that PI unless it's under 2, in which case then we worry about different complications, which I will get into. So this is the HeartMate. This is a HeartMate 3 controller in comparison to a HeartMate 2 controller. As you can see, they look identical, except for the colors are inverted. And besides the speed, essentially all the external equipment of both HeartMate 2 and HeartMate 3 are the same. In the HeartMate 2, the speed runs anywhere from 9 to 10,000. You may see as low as 8,800. In the HeartMate 3, it runs anywhere from 5 to 6,000. And then this is the hardware controller. The hardware controller, as you can see, looks different. Everything is displayed right on this front screen. So it also has a speed, which we set. It also has a calculated flow and a power. There is no PI that's calculated by the hardware. And then any electrical source would need power. So you can either connect to the wall, which patients have cords that connect to the wall for when they're sleeping, or you have batteries. Now for the HeartMate, they have these 9-volt batteries, pretty heavy, but they can get you up to 15 hours of battery life. They snap into a clip. The HeartWare has these smaller batteries. Together they get about 12 hours. So I will start with the HeartMate. And again, they're pretty interchangeable from a nursing point of view, except for the numbers, like the speed and things like that. So if you're ever at a patient's house, what they do is they'll wake up, they'll be connected to their wall power. Usually the first thing they do is put themselves on batteries. So if you're ever going to help a patient put themselves on batteries, it's actually pretty easy. Inside each of these are the connectors. Inside each of these is a half moon. And there are pins in there. And it goes into a clip, which also has a half moon and pins. And it basically is as simple as pushing it in and tightening it. And then to add a battery, you line the red arrows up and it snaps right into place. Patients are able to tell how much battery life they have by pushing a button right on the front, or there is a button right on the front of here that will tell you how much battery life there is. And I can hook this up. I apologize, it makes a lot of noise, but I'll go ahead and hook it up so you see what I mean. Okay. So, by simply pressing that button, you can see that the patient has full battery life. So either way they can check. Now for a HeartWare, it's very similar. The battery just goes right into the side and clips in. Now the difference in terms of the battery life is the HeartMate will pull from both batteries at the same time for a total of about 15 hours. The HeartWare will pull from one battery until it's almost completely drained, down to 25%, and then it switches to the other battery. Once both batteries get down to 25%, it will beep to change power sources. Whereas the HeartMate, like I said, it'll drain from both at the same time, and once you get down to about 15 minutes, it'll alert you that it's time to change. We educate these patients to try not to wait until they're down to their last 15 minutes to change batteries, but they often do. Some even push it further, so there's a diamond on here that turns yellow when it's time to change your batteries. If patients decide that they're too busy and ignore that and get down to 5 minutes, a red battery will light up and a loud alarm will sound. Let's say that they think, I have 5 minutes, I'm gonna keep doing what I'm doing. And they get down to no battery life. Now lucky with the HeartMate, there is a backup battery that lasts for another 15 minutes. However, this will not stop alarming until that is addressed. And it will start a countdown on the front. I can kind of demonstrate that for you by taking it off power. As you can hear, it will let you silence it for 2 minutes. But as you can see, the red battery will light up. It's telling you to connect power immediately. There is a clock on the front that is counting up to 15 minutes. And in this case, it is telling you that both connectors are devoid of power. So as you can see, these two lights connected to the power are saying there's no power. If you were ever short one battery, it will tell you which connector is the one that needs the power source. So it's pretty user-friendly in that case. So if you ever were at a patient's house and wanted to check their numbers for us, if we call and say, well, patient's not feeling well, what is their flow right now? For the HeartMate, it's pretty easy to do. You just hit that display button. And I tell people that this display button, the display screen is a square, the display button is a square. So that's how you can connect the two. It'll show you the speed, it'll show you the flow next, then it'll show you that PI number I talked about, and then it'll show you the power. It also tells you that the backup battery inside is charging, and then it goes off. And then I say, well, has the patient had any alarms? And you tell me, yes, they did have an alarm, but they don't know what it was. The way to check it is you would hit the alarm button and the display button together, and it would pull up their last 6 alarms. And you can just scroll through them by hitting the square like you would to check their numbers. And that's a good way for us to know if something happened, they had an alarm that maybe they aren't aware of. Unfortunately, a lot of patients, though we teach them this, don't remember that. So that's something that you can help them with if they are concerned or they do say they have an alarm. And then obviously this is the silence alarm button. It's a bell with an X through it. And then you have lights that go up the side. One shows whether or not the driveline is connected, and the two connect for each of the power sources. Now with the HeartMate, you will have alarms. We ask that you call us for any alarm that is not a power-related alarm. So if the alarm says change power sources, low power, that's something the patient can fix at home. However, any other alarm we need to be called. It may be something that's simple to fix, but we just ask that you call us. And even so, it will tell you on the front what to do, and usually it says call hospital contact. Different alarms that people can get include a driveline fault, something's wrong with the driveline. Something's wrong with the controller, a controller fault. In the case of the red heart alarms, you would get a low flow, or something is wrong with the device or the power source. So the HeartMate is designed to detect an alarm for any flow that drops below 2.5. That is not a flow that is deemed to be able to sustain a patient of any type. So it will alarm and it will not cease alarming until we somehow fix the problem. And a lot of times it requires somebody to be admitted. So if they ever have a red heart alarm, that's immediately a phone call to us. If the patient is in any distress, that's a call to 911 and then to us. We always ask that you take care of the patient first, so if you need to call 911, please do so. You're usually never wrong in that circumstance, and then let us know. Now, with the Heartwear, the numbers are displayed just right on the front. If there is an alarm, there is a scroll button that you can scroll down on, and then there is a silence alarm button. Right on the front, it will show you the power, the battery, how much it has left, and then the triangle in the middle is the alarm display. So it will display either a yellow alarm, a flashing yellow alarm, or a flashing red alarm. And again, unless it's a power issue, it means to call us, and we will troubleshoot how to fix it. Now, something about the Heartwear that's different from the HeartMates, if you could see this little red pacifier on here. This port is where we connect our cables to be able to read the data in clinic. We have monitors that we can connect and see all their history, any alarms, things that the patient can't see. We can make changes to their speed and things like that. With the HeartMate, it's simply connecting the white port to our cable. But with the Heartwear, it connects through here. At home, they have this little red pacifier. It should never be on the patient. So if you ever walk into a patient's house with a Heartwear and they have this red pacifier on, it needs to come off immediately. We call it a pacifier because just like you would with a baby, put a pacifier in its mouth, it stops crying. Put this on the Heartwear, it stops alarming. So if a patient has this on and is having an alarm, it's not going to sound. And if it's a life-threatening alarm, they may not realize it until it's too late. So this should always be off and the port should always be on. And we ask that they keep it either in their backup bag or on their backup controller. And it's useful when you're switching controllers because it silences the controller. And speaking of the backup equipment, patients should always have a backup controller and 2 fully charged batteries with them anywhere they go at any time. When you're visiting or seeing them in their home, it should be readily available. Not necessarily in the same room. People switch rooms all the time, but they have to know where it is and it has to be readily available in an emergency. Anytime they leave the house, they have to have this equipment with them. So if by chance you're visiting them and you're seeing them as they're leaving to go to a doctor's appointment, just make sure you remind them because we have quite a few patients that come to clinic without their backup equipment. They seem to think that we will take care of it when they get there, but we do not have backup equipment in our office, so we like to encourage patients to bring their own. I know I went through a lot just there, but are there any questions? I'd like to pause and see if anybody has any questions or anything I can refresh that I talked about so far.
You were saying that, okay, to qualify, their EF has to be less than 25%. So what does this approximate in terms of ejection fraction?
So to repeat his question, he wanted to know what the pump would calculate in terms of ejection fraction once it's implanted. So we don't look at ejection fraction with the VAD. The patient will still have an ejection fraction of less than 25%. Okay. However, we look more at patient symptoms. Are their end organ function? Is the renal function okay? Their liver function okay? How does the right side of their heart look? We frequently do echoes, what we call ramp studies. So we will do an echo and adjust their speed up and down to see how well their VAD is unloading their ventricle. Ideally, we like their aortic valve to be closed most of the time. If it's opening frequently, that means their native ventricle is doing a little too much of the work. So we like it to be closed either fully or open only maybe every 2 to 3 beats. That's a good question. Anybody else? Okay. So as I had said before, that they have to have an EF less than 25% to qualify. Now there are 2 indications for the LVAD, and you may hear patients talk about this at home. There's destination therapy. That is for patients who, this is the end, they don't have options past the LVAD. These are patients who are either past the age limit for a transplant, have other chronic issues that preclude them from being considered for a transplant, have a BMI greater than 35, are medically non-compliant, or have a history of substance or tobacco abuse. Now, patients who start off as destination don't necessarily stay destination. They could become what we call BTT, and that is bridge to transplant. Those are patients for whom they qualify for transplant or may qualify for transplant in the future, but are either too sick or have an issue such as their BMI, substance abuse, that they need the VAD in the interim to make sure that they don't get too sick. Those patients that have issues, like I said, weight or substance abuse, we can contract. Usually it's about 6 months or until their BMI becomes less than 35, and then we can consider them for transplant. A lot of patients will go home and tell you that they're on the transplant list. This might be true in some cases, but it might not be for everybody. But that is how we distinguish who is eligible and who isn't. But the VAD is great at helping the patients feel better, helping improve not only their quality of life, but again, their organ function, and getting them into good shape for transplant in the future. Now, because the flow of the LVAD is continuous, you may not be able to access pulses. You also may not be able to get a blood pressure. Now, in these cases, we always do a Doppler. You can absolutely try to get a blood pressure with a cuff, because some patients you may be able to get one, but it's best to do a Doppler on everybody, at least initially when you go see them, because even if you can get a cuff pressure, it may not be accurate. So I will show you how to do one for those of you who do not know. So it requires a blood pressure cuff that's not quite like this, but this is all I had. You wrap it around their arm, and then you take a Doppler. You squeeze some gel in the area of where their pulse would be. You take the probe and you find their pulse. Once you find it, keep your one hand there, and with the other, squeeze up the blood pressure cuff. Once you get it, the same as you would checking anybody else's blood pressure, about 20 above where you think that they would be. And then you let it go. The very first sound you hear through the Doppler is your MAP, mean arterial pressure. We like our patients to run less than 90 and above, preferably above 65. If you ever get a blood pressure that's higher than 90, we ask that you correlate it with the cuff pressure, because sometimes patients who have a little more pulsatility, their afterload will be higher, and that may be a systolic. So absolutely call us if your blood pressures are greater than 90 or your MAPs are greater than 90, but check it with the cuff pressure too, just for correlation. Anyone have any questions on how to do the Doppler?
I have a question then when we're documenting the numbers we're getting, because like you just said, you get a MAP instead of systolic, so when we're documenting it from our standpoint, how would we document that?
So you could say a Doppler MAP,
Okay.
say you got 100. You put Doppler MAP 100 and then cuff pressure and say it was 102 over 68. And then depending on if you use an automatic cuff, usually those spit out a MAP, but not always. So if they don't, then...
Yeah, we have all manual. We're pumping them all up ourselves. So.
And you may not be able to hear anything. So usually and the patients may have a automatic cuff pressure that you can use. Some do display the MAP, some don't. If they don't, just the systolic and diastolic is fine.
And you would always want the nurse to call if it was greater than 90?
We do need to know if it's greater than 90. And like I said, that's one of the reasons it's nice to be able to correlate it, because sometimes we'll say, okay, what is the systolic blood pressure? What did you get? And if you can't get one, that's absolutely fine. A lot of times we may or may not treat, depending on the patient's history. If they have a history of hypertension and it's been difficult to control, we may adjust their meds or we may just see them in clinic, but it is good to know. And then other things that are good to know, again, we talked about the signs of infection of a driveline. If the patient has persistent dizziness, with the LVAD, there's a lot of changes in their autonomic nervous system that can cause dizziness when they rise, when they bend over to tie their shoe. Those are perfectly normal. Dizziness that persists or causes syncope are things you want to call us about. Again, we talked about fevers. Any signs of bleeding. So if the patient says, oh, I've been having dark stools, I've been having blood in my stool, I've been having blood in my urine, I've been having urine that's darker than usual, things like that, you want to let us know. Any patients obviously that complain of worsening shortness of breath, that have gained 2 to 3 pounds in a night or 5 pounds consistently through over 5 days. Patients that have abdominal distension or worsening edema. Patients that just don't feel well. It's best just to call us and let us know. We can kind of talk through whether or not the patient needs treatment, needs to be seen, things like that. And again, we may ask you about the numbers. This one you would just scroll through, and the heartware, it's displayed right on the front. So it's easy to see. Now, something we teach the patients to do that I would never expect anyone in here to do, but it's nice to know just the basics of how to change a controller. Now, we always ask the patient to call us if they ever feel that they need to change their controller. Some do it without speaking to us, but we always ask that they call us because a lot of times it's not necessary. But if it is, then we do talk them through how to do it. And the order we do it in for a HeartMate specifically is power, patient, power. So what we do is we have them get out their backup controller, put on a power source so that there is a power source running this backup. And then they will take the drive line and move it from one side to the other. And then they take the second power source and move it over. Now for the HeartMate, as you can see, where the drive line comes in, there is a little door. You open the door, you press the red button, and pull this straight out. And then there's an arrow that lines up, and it goes right into here. And I can demonstrate if you would like. I could do that for you. Okay, so the first thing you would do is you would switch the power source. And you may have to silence these a lot because they will make a lot of noise. And then next is the drive line. So again, you flip that door open, you press that red button, and you pull this straight out. Now, there is an arrow on here, as well as an arrow on here that goes straight in. You hear that click? And immediately it starts moving again. Then you shut the door. If you put it in and you think, okay, it's in, and you try and shut that door and it won't shut, it's not in. You just pull it out and start again. And then you move your second power source over. And you're done. However, this one's upset because it thinks it needs a drive line. That's the last thing it remembers. So you would put it to sleep by pressing this battery button. And I like to think of it as you're putting the battery to sleep. So you hold it, and it'll count down for you. And voila, it's asleep. And the patient has their new controller. Looks easier than you will think it is at the time, but if you follow the steps and ignore the alarm, it's actually pretty easy. And again, we don't expect anybody to do that. It's just nice to at least know the steps, so if the patient's panicking and they're not listening to us and we're trying to yell through the phone and there's chaos, there's somebody who says, okay, I remember doing it this way. Now, unfortunately, I don't have the drive line for this, but what I tell patients to do when I'm teaching them is to put it on top and follow a U pattern. So the backup will have the pacifier, and you'll follow a U. So you will take a power source from one and move it to the other one. You will take the drive line, which pulls straight out, and it has a little red button on it that matches up to this little red button on here. And you put that in. Both of them are going to be screaming at you. So then you move the pacifier from one to the other, from the one that was on to the backup, and then you move the last power source. So just follow the U. Power, patient, pacifier, power. And that is that.
What are reasons they would have to change their control box?
So if they had a controller fault, if something happened to one of the clips, so sometimes patients are a little rough with their equipment. They run into something and this cracks and you no longer are able to connect to the clip. Unfortunately, these things, while they will run on one battery, they will alarm until they get two. So you always have to have two power sources on your controllers. That works for both the Heartwear and the HeartMate. So if the clip is damaged and there's no way for them to connect to, we will ask them to change the controller. That is not an emergency per se, but an unfortunate complication. And again, if the controller's not working or we just suspect something is wrong with the drive line or anything like that, we may ask. And sometimes for reasons we're not sure of, the controller may just completely stop working. In those cases, I say try and switch the controller, and if it's still not working or if it's a pump issue, then we call 911. And I had mentioned, and I apologize, I didn't mention this before, that this has a backup battery. The hardware does not. So if the hardware is completely disconnected from power, it will stop. So it's especially important for these patients to switch their batteries and make sure that they are fully aware of when their batteries are running low. At night, people with the HeartMate will sleep on wall power. So it's a cable that connects to a power module that plugs into the wall. And there's a port for each of these connectors. The Heartwares, they sleep on one battery and a port that connects into their other power source to the wall. So if there's ever a power outage in the middle of the night, the Heartware will switch to the battery. It will alarm because it wants that second power source that's been taken away, but they'll still have a functioning VAD. The HeartMate, unfortunately, if the power goes out, the power source goes out, but they do have that backup battery. It will just alarm until they wake up and put themselves on batteries. Questions?
Does the LVAD have any sensitivity to, because obviously these people aren't going to be running marathons and stuff, right? You know, so like, does it have any sensitivity to cardiac demand? I mean, will it increase at all, or?
No, so the speed will stay the same.
Okay.
The speed can fluctuate. With the HeartMate, it's supposed to be able to fluctuate up to 100 in either direction. The Heartware usually goes anywhere from 20 to 40 in either direction. It does have those small fluctuations. With the HeartMate, there is a low set speed, and I apologize, I didn't repeat his question. He wants to know if there's any increase in the VAD power for cardiac demand, such as exercise, things like that. So again, there is small fluctuations in the speed, but once the speed is set, it's pretty much set. Patients may feel exercise a little bit more. They may become a little more short of breath with vigorous exercise, long distances, higher cardiac demand. But the VAD usually is pretty good at compensating. The heart rate may go up, so you may see a little bit more, blood pressure may go up because the heart rate's got a little more afterload, but essentially we try to optimize the VAD so that the patients are able to tolerate exercise. Any other questions? And is there anything I didn't touch on that? Okay. All right, so thank you. And if anybody has any other questions, please feel free to email me. It's Nicole, Necole .Tibolla, TIB as in boy, OLLA @atriumhealth.org. I'm happy to answer any questions, and I'm happy to come and demonstrate again. So thank you. Oh,
And
I'm sorry.
Also, so all their dressing stuff will come from you guys, right?
Yes,
We
we
won't
provide.
order any of that.
No,
Okay.
we provide all their dressing supplies. We may ask on occasion if they forget to ask us and they're out, maybe to supply a couple of things, but that's very rare. We will overnight supplies if they need them.
Reminds me, is there a cap on the end of the driveline where it comes out of the body, you know, to hold it in place? I mean, is there?
So there is not a.
Anchors it, I guess, you know, like a peg tube, you know?
So there is not, he asked if there was a cap to anchor the driveline to the body. So initially when the surgeon implants the VAD, he puts a little stitch at the site to kind of train it to stay in place while it heals. And that usually comes out anywhere from 3 to 6 weeks after surgery. It'll get removed in clinic. But the VAD develops scar tissue both inside and at the site, and it's usually pretty anchored. That being said, there is movement at the driveline site. So part of the driveline dressing is a Foley anchor, and we always ask that they have their driveline secured in this Foley anchor. So if they're missing the Foley anchor, please encourage them to wear it. If they refuse, please let us know. Trauma is the #1 cause of infection in driveline sites. So any movement, even just a little bit like this, can irritate the site. It breeds bacteria and opens it up to infection.
How often do they change the dressings, the sterile dressings?
How often do they change the dressing? Initially, it's every other day. Once they get a couple months out, about 3 to 6 months out. They could go to every 3 days. And then once they're significantly out, patients will go anywhere from 4 days to a week if they're doing well. So,
What
and
is the time frame that patients usually have the LVADs? Like
so the time frame for LVADs depends. If they are destination, patients, average time is about 5 years. With our patients, that's usually what we see, but Abbott, the company that makes the HeartMate, has seen patients live up to 10, 11 years. A lot of these patients are those that are aged out of transplant, so they're in their 80s, 70s, 80s. For bridge to transplant patients, it really depends on the center, their complications, things like that, as to whether, so some patients may wait 2 months, some patients may wait 2, 3 years. It really depends. Patients can undergo pump exchanges for various reasons, such as infection, electrical faults, if they develop a clot in their pump. So some patients can get new pumps. But ultimately, these patients still have heart failure. This doesn't cure the heart failure, it's just a treatment option. So for those patients that are destination therapy, they usually succumb to a complication, that being right heart failure, severe life-threatening bleeds, strokes, infections. Those are the main complications we see in LVAD patients. Untreated driveline infections can lead to blood infections, which can kill the patient. Patients who don't take their Coumadin properly on time, miss doses, don't get their INR checked, those patients can develop clots, which can lead to the pump and stop the pump, or it can cause a life-threatening stroke. Again, the pump is just on the left side, so unfortunately we have to optimize their meds to try and make sure that their right side is functioning. And in a lot of these patients, they develop right-sided dysfunction. We treat them as long as we can, but ultimately a lot of them, that's what they pass from. And patients with right-sided dysfunction tends to lead to renal failure and liver failure. And then some patients, unfortunately, bleed a lot, and no matter what we do, we take them off of Coumadin in severe circumstances, but that is another complication. So
most of them are on Coumadin, or all of them?
almost the only time we take, so she asked about all our patients being on Coumadin. All of our patients are on Coumadin to start with, and a full dose aspirin. Initially, we run everybody's INR from 2 to 3. Patients with bleeds, we may run them a little lower, or hemorrhagic strokes, we may run them lower, and vice versa. Patients with embolic strokes or clots in their pump, we'd run higher. We will always let you know what their INR goal is and what we want to do with their Coumadin when you call. In patients with severe recurrent GI bleeds, we may stop aspirin. What we would do is reduce aspirin to 81 milligrams, then stop it, and if they continue to bleed, then we do eventually take them off Coumadin. But that's pretty rare. And then the patients that do have a propensity to clot, you may see them on Plavix as well. So, yes.
Showering.
Good question. So she asked about showering. All of these patients have a shower bag that we teach them how to use before they leave. In fact, our physical therapy team at Maine is in the process of doing a project where they have all the patients shower prior to being discharged, so they've had that practice. And I mean, we show them how to use the shower bag, but it's one thing to be shown versus actually getting into the shower for the first time. So we thought we'd help them by helping them with that first step. They will have to cover their driveline dressing. We recommend either press and seal saran wrap, or sometimes I tell patients to cut a Ziploc bag to the shape of their driveline dressing and put some tape over it. And something else I was going to mention about the driveline site, you may see 2 different types of dressings. So we teach everybody how to do what we call the Cardinal kit, which is a Tegaderm, and they clean it with ChloraPrep. Some patients don't tolerate the alcohol on their skin very well, or the Tegaderm. In those cases, we switch them to what we call the HibaCleanse gauze method, where we give them pink HibaCleanse soap, and they teach them how to clean it, and then they put gauze and tape. So it may vary what dressing you see, but from your standpoint, what we want you to focus on is, 1, that they're using sterile technique, and 2, if they have any signs of infection.
Yeah, do they have like a little bag or something they put the pump and everything in, or where?
So she wants to know where they put the pump. Patients are very creative with how they wear their equipment. We discharge everybody with a shoulder bag that the company makes. However, patients will go get concealed carry vests, fishing vests. Some patients have shirts that they make that have pockets sewn into them. Some women tend to throw their stuff into a coach bag or other kind of purse, which, as long as it's properly contained and the driveline is not compromised, we're okay with. I try to discourage those kinds of things because you just throw everything into a bag and everything gets crumpled up. Some people just stick them in their pockets. But we do discharge everybody with a bag. So, any other questions?
Can you actually, you got it there for demonstration purposes, but what about what you hear? I mean,
You mean when you're,
Yes.
He wants to know what you hear when you're actually listening to a patient.
yes.
So for the HeartMate 2 and the Heartwear, what you would hear is basically a continuous hum. You may hear slight fluctuations in the hum with the heartbeat, especially if they have a stronger heartbeat, but it's continuous. With the HeartMate 3, you hear more of a musical sound. As I talked about in the beginning, it mimics a pulse by dropping its speed and then coming back up to its set speed. And it does that every 2 seconds at a rate of 30 an hour, or 30 a minute. You may hear that it sounds almost like a doo-doo-doo sound as it does that. So that's the difference with the HeartMate 3. Now, and I'm not going to go into this too much because we don't have too many of these patients, but we do have total artificial hearts out in the community. Only a couple. So it'd be pretty rare for them to come across you guys, but that sounds like a horse galloping, pretty much, is the best way. It's very loud. You can hear it outside the body. If we increase our implantation of those patients, I can do another demonstration for that. But yeah, it's either continuous hum or a little musical sound. If you don't hear anything, then you need to call us, please. That's an emergency. So, okay. Any other questions?